Hi there, I'm Harry Nelson, and I'm delighted to be with you today to talk about behavioral health in the time of COVID-19, questions around the leap to telehealth. I've spent a lot of time these last 15, 20 years working on questions in behavioral health and questions in telehealth. What's been really exciting in the last couple of years and in the last couple of weeks and months is the accelerating pace at which they are truly coming together. And they've been a focal point of my work, of my thinking, of my advocacy, and I'm really excited to have a chance today to share some thoughts with you about them. So I want to dive right in. I think we are at a crisis moment in behavioral health. By the way, it's not that I think we weren't there before COVID-19. When I wrote The United States of Opioids a couple years ago, I tried to talk about the opioid crisis as a marker, or several markers, a pain crisis, a drug overdose crisis, that were markers of a broader crisis, of a series of epidemics of anxiety, epidemics of depression, epidemics of suicide, and drug overdose death that my friend Steve Grinstead refers to as a syndemic, a series of overlapping epidemics. And so one of the data points that was really striking to me in writing The United States of Opioids that I want to call your attention to was something that the University of Pittsburgh Medical Center put out in September 2018. And what they did was they showed that even though we were talking about a rising year-over-year opioid overdose crisis from prescription painkillers, from heroin, from fentanyl, when we looked back, we actually saw that there was an ongoing 40-year epidemic, 40 years of exponentially increasing year-over-year drug overdose deaths, a lot of different sub-epidemics in that information, but it suggests that there was a market efficiency to the market for the drugs that were killing people, and it suggests that the problem was not any one drug. And I, in the book, tried to call attention to the fact that when you put together the drug overdose deaths and the alcohol deaths and the suicides, you end up with a pretty staggering number, something like 200,000 Americans, and rising every year, ending their lives in these ways. And of course, that is just the tip of the iceberg of the behavioral health problem. And that's the way that I would think about it. The people who are dying from the behavioral health crisis are the tip of an iceberg that gets very, very wide at its base. And that is one of the stories of COVID-19, is the extent to which we are realizing how wide the base is. And before I turn to that point, I just want to highlight that my belief is that we really need to tackle all of the behavioral health issues in terms of talking and eliminating the shame from our vocabulary around feeling isolated, right? Isolation has been a big theme in the last couple months, as we have truly been isolated in our homes, particularly people who are alone without partners, without family members, and also the extent to which we are under chronic stress. We were isolated before COVID-19. COVID-19 has shined a light on a profound isolation that got worse. Chronic stress has been an issue that has been with us for decades. America is uniquely stressed. That was one of the points that I tried to articulate in From Obamacare to Trump Care. I think it's part of what differentiates us from many other developed countries. And COVID-19 has shined a light on the chronic stress issue that we're under, the anxiety, the depression, I can go on, the post-traumatic stress disorder. We have really been in a state of crisis on these issues for a long time here in America. When you look at our data, it's not to say there aren't also problems in other countries, but we have a unique and distinctive problem, and it was a crisis before this moment. But COVID-19 has taken us to another level, and I want to just highlight these two headlines, one from the Washington Post, a story on the coronavirus pandemic pushing America into a mental health crisis, another from Kaiser Family Foundation. The numbers are staggering. More than half of all Americans are reporting mental health symptoms getting worse, and I think we need to realize, I want to say this really about three different groups. We had an existing group of people who were being treated and had access to our behavioral health system for problems before COVID-19. We have a growing number of people who I believe are more and more aware that they need help. And frankly, all of us, or most of us on some level, are feeling the symptoms. The Kaiser Family Foundation study talks about 56% of Americans experiencing one or more mental health symptoms, whether that was excessive alcohol use, short-tempered anxiety, depression, feelings of hopelessness. These are widespread problems. These are not isolated, small things that only a handful of people are feeling. These are widespread phenomena. And I think that COVID-19 is shining a light on the fact that these problems are there and that we need to do something about them. So the next thing I want to say is that this period of COVID-19 beginning in March has been a watershed moment for telehealth. And we see that in this study from McKinsey that I think is a good way of accessing the numbers. Telehealth has gone from being perceived of pre-COVID-19 in 2019 as a $3 billion industry to an 80 plus times multiplier. It's now viewed as a $250 billion opportunity. A volume increase of 50 to 175 times. Adoption from 11% of all consumers in 2019 to 46% today. Those are staggering numbers, and they point to a radically different situation in telehealth. The outlook for telehealth has changed dramatically. I think we were forced into it, right? Providers were not going to go into the office or go into patients' homes. Patients didn't want anybody in their homes, and so telehealth has really filled an enormous gap. But one of the first questions I want to ask is, how far are we thinking and how broadly are we thinking about how behavioral health can fill the gap? When we talk about access to behavioral health, we generally are talking about counseling services from professionals, whether it is mental health professionals providing psychotherapy, talk therapy, whether it is people doing applied behavioral analysis with kids on the autism spectrum, or we talk about outpatient programs, we talk about medication-assisted treatment and residential programs, inpatient programs, and we're talking in a very narrow range about a continuum of acuity from under which we treat behavioral health. But part of what I tried to argue in the United States of Opioids is that we really need to rethink this because it's far too narrow a vision of where the problems are. And that goes to what the Kaiser Family Foundation report is highlighting, which is that the reality is that behavioral health problems exist on a vast continuum from people who are experiencing symptoms but managing them largely by themselves or with limited levels of support, with educational resources, with digital therapeutics, all the way to the higher acuity setting. Part of what the disservice that we do is that we shame people who have a higher acuity issue by creating a binary that you either have a mental health problem or you don't. And the reality that I tried to address in the United States of Opioids was to say, we need to rethink that. We need to eliminate the shame. And part of the way we do that is by acknowledging that we are all suffering in this moment from behavioral health challenges, from mental health challenges. I talk personally in the book and in my book tour quite extensively about my own anxiety and insecurity. And I think that if we are honest in this moment, there's so much work and so much opportunity. And the point is that we have to stop talking in the limited framework of people who need a professional intervention. That's important. We need to deliver that. But we also need to talk in terms of educational resources and digital therapeutics and tools that we can provide, resources that we can provide online. Last night I turned on the Calm app to do a meditation. I tricked out 10%, another meditation app. That was part of my behavioral health work, and we need to rethink those resources and many, many more. Those are just narrow examples that I'm taking from my own life, but those are behavioral health resources that we need to be making more accessible and more available. Because one of the big questions that I think we can answer if we think broadly and ambitiously here is, how do we reach the right people with the right resources at the right time? And the reality is that behavioral health problems manifest dynamically. They change from time to time, from day to day, and different people need different resources at different times, and we need to think in terms of how telehealth can meet those resources. So I want to shift gears for just a minute and talk to you as a lawyer about some of the challenges that we have in using telehealth in behavioral health. And some of the core questions that come up are, which services translate effectively? And that is a question of standard of care, right? The standard of care what we've come to is telehealth. The standard of care doesn't change, and so the question is, how do we meet standard of care? How can we tell what is actually effective? Right? There's a lot of disparaging statements. If you read a lot of telehealth consents, you'll see disparaging comments about whether telehealth is as effective as in-person settings. We as human beings can read each other better and convey emotion better in person than we do digitally. But we have to assess effectiveness and figure out how to demonstrate effectiveness within telehealth and how to measure outcomes and demonstrate that telehealth is doing the job at all levels of need in behavioral health. We need to address the safety issues. There's a lot of concern, and this too shows up in the informed consents that we see for telehealth around what's appropriate to treat with in a telehealth setting, and the risks that people have, that certain people may be at risk and need access to people around them because they're dealing with difficult issues or may be at risk of self-harm or other similar risks. Right? We have certain settings in which we need in-person, face-to-face meetings, often sometimes for medication, sometimes simply because insurance companies insist on it. And we've got to address those issues if we're going to make telehealth more accessible. I want to talk about a few issues that are really that I think of as legal regulatory barriers that need to be addressed. We still have 20 states that require an informed consent for telehealth. California happens to be one of those. And I think it's time that we make a hard push to eliminate informed consent requirements for telehealth. The reality that we've seen in this time of COVID-19 is that telehealth works for so much of the behavioral health needs that we have out there, and there's no reason that behavioral health providers should be second-class citizens required to obtain consent to the use of this modality of care. That's a simple one. One of the really revolutionary things in this time period has been the move away from state licensure as a barrier. Now, it's only been with respect to physician care that the Section 1135 waiver from the Department of Health and Human Services said physicians can practice across state lines. This has been exciting to see a period in which at least physicians are freed from those barriers. And I suspect that we're going to return to state-by-state licensure, but we should recognize that that is a barrier that is limiting people from accessing telehealth. Years ago, I helped create a network for social work provision, and it was one of the first ones in the country, and it became incredibly limiting that for certain states we could not find licensed social workers to participate, and we need to go further in reducing that as a barrier. And then finally, the big barrier that we need to talk about is the barrier of coverage and reimbursement. One of the most frustrating parts of this whole last period of months has been talking to providers who are discovering the extreme limits that certain payors put on coverage. Right? I was dealing with a provider who had somebody in need of outpatient services for a substance use issue. And unfortunately, this family had TRICARE, and TRICARE only covered professional counseling. It didn't cover outpatient programs. So we see that a lot of payers have arbitrarily narrow coverage scopes. And we also see that there is just simply not parity on coverage and parity on reimbursement. California was a state that last year took a huge step forward on parity for reimbursement, but it did so really for in-network, and it did not impose any obligation on payers to pay for out-of-network telehealth. That is a reflection of a discrimination that still exists against telehealth providers. We need to get true parity where whether you're in-network or whether you're out-of-network, you are covered and reimbursed fairly for providing telehealth services. I want to take a step back in our last few minutes together and ask some big questions. Right? One of the biggest questions that I have is, how far can telehealth go in fixing our behavioral health problem? And as I was asking this question, I was reflecting back on one of the questions that I asked when I co-authored From Obamacare to Trump Care, which was how can we fix what's wrong with U.S. healthcare? So fixing what's wrong with something requires understanding what the problem is. And I just wanted to share this slide, which is near and dear to my heart. The simplest way to describe what's broken in U.S. healthcare is that we spend more than any other developed country for a product that is worse. We spend $8,200 and change. I'm sure that number's gone up because that's 2 or 3 years ago relative to other developed countries, European examples, between 2,700 and in the low 5,000s that are providing a better product, a better healthcare as measured by not only by price, but better healthcare as measured by quality, better healthcare as measured by outcomes, better healthcare as measured by access to care. And our system suffers, and our behavioral health system more than most, right? We are really only barely 8 to 10 years into a remaking of behavioral health post mental health parity, post Affordable Care Act, forcing it into every benefit plan in America, and we still have a long way to go. But when we look at that issue, when we look at can we fix the problem of how much can telehealth fix behavioral health, we should go back and look at all of these measures. How much can telehealth fix access to care in behavioral health? I submit to you it can do it quite a bit. We can make a lot more care accessible through telehealth, particularly when we start looking at resources, at educational resources, at digital therapeutics. But across the board, we can expand access. We can improve quality with the heightened efficiency of care. And we need data out there to support quality and outcomes. But I believe that there's no question that telehealth, we will be seeing proof in the coming years that telehealth is going to demonstrate improved quality, improved outcomes in behavioral health. We'll be able to measure areas where we struggle at these times. And I want to go from that question to kind of a last question, which is how much can telehealth help us close the behavioral health gap? The gap between our behavioral health system and the system in the rest of the world, the gap between the system that we have and the system that we need. How much will telehealth move the needle? So From Obamacare to Trump Care, the case that we made, and this is backed up in the book by various studies, is that really the opportunity is not just about efficiency, right? Efficiency, better healthcare service and delivery only moves the needle 20%. And the challenge is that 80% of the opportunity is really not in clinical care delivery. That's not the answer, right? It's addressing lifestyle issues. It's addressing education. It's addressing social support. It's addressing the other things that people need, housing and nutrition and so on. And I think this ties into the last point that I want to make about telehealth and behavioral health, which is that we can definitely use telehealth. The sort of narrow opportunity in front of us is just to make things more efficient, right? We can close that gap 20% or so by just using telehealth to have a more efficient system of behavioral health. The real opportunity in front of us is the 80%. And that goes back to the point that I was talking about a few minutes ago, which is that just by expanding our thinking about what constitutes behavioral health, about expanding our thinking about what constitute behavioral health needs, by addressing them in a way that strips away the shame and the barriers to access, we can make a profound difference. We can address those non-clinical issues. We can help address the loneliness and the isolation and the despair that's out there, and we can set a mission for transforming our behavioral health system digitally to do all the things that we are just falling short on. So I hope that that's a useful way to begin this conference and to frame the other presentations that we're going to be hearing today. I'm so excited to be participating today and really grateful for the opportunity to share ideas. And I look forward, if anyone has thoughts, questions, feedback, grievances with anything I've said, please feel free to reach out. And I want to thank you so much for having me as part of the conference.